Oh, there we go. Can everybody see the slide okay?
Yes.
Great. So thank you very much. Technology and all that, it's always tricky, isn't it? My name is Colette Hawkins and I'm a consultant in palliative medicine, and I'm leading research to understand better the experience of legal needs in the context of life-limiting illness. And we're looking to investigate routes to meeting these more effectively. And I'm here with Hannah Hessel-Greaves. Hannah will be explaining a bit more about the methodology which is underpinning our ARC-funded project. And that project starts next month. And we're here on behalf of a multi-professional team. So just a very brief introduction to the team. Sarah Gorman, some of you may know already, is representing social prescribing. She also leads a community project in Gateshead, so has a double hat. Hannah, Mike Martin and Rob Wilson from Northumbria University are experts in the complexity-informed approach that Hannah will be describing in a bit. Jonathan Ling from Sunderland University is Professor of Public Health, so he brings that perspective into the mix. Jane Butler is Head of Income and Development at the Law Centres Network. Charlotte Emmett is Director of Learning and Teaching at Northumbria Law School and an expert in mental capacity law. And Hazel Genn is Director of the Centre for Access to Justice at University College London and an international expert on social welfare law. So we are a mixed professional group. And over the past 3 years, we've been building our understanding of legal needs in the context of life-limiting illness using funding from an organisation called the Legal Education Foundation, which is a really dynamic and positive organisation. And we've been pulling together quite a large national stakeholder group. And some of the larger organisations are on the slide here. Bringing together organisations which represent health or some aspect of daily life which might impact on people who may be towards end of life. And it's been really important for our work to have that breadth of experience and perspective that these different organisations bring. And that's really what we're intending to continue with, that broad reach that's crucial to the way our research is progressing. So that's by way of introduction. A couple of key foundation points that I want to make to set the scene. One is to say that law and health are inextricably linked, and that's a crucial point. But that relationship is poorly appreciated in healthcare settings. These things have a consequence on health and well-being of the people that we're looking after, and also health service utilisation. And therefore there's a need, but also a big opportunity for improving this area of care. What I'd like to do is to show you a short story. This is about a 4-minute long video, and this was the experience of somebody that we came in contact with last year as part of our research. And I think that this is probably the best way to illustrate the points that we're wanting to make. I think I've enabled the audio, but if I haven't, Dennis, would you tell me before I get to the end of the video? But hopefully you can hear this okay. So this is Dave.
My name's Dave, and I live.
And hear perfectly.
Great, thank you.
These last 6 months have been a nightmare for me. I was feeling ill, just not myself, but it came on slowly, so I just ignored it at first. Then I started with headaches. My vision wasn't right, and I couldn't eat properly. I went to see my GP, but he couldn't find what was wrong, so he sent us to see a specialist at the hospital. All this time I was struggling with my job. I was working as a machinist. I've been with the company a good few years. I needed a bit of time off sick. I'd never asked for it before. And my employer kept pushing me to work, but when I told him I wasn't well and I couldn't do the job because of my eyes, well, he sacked us. I told him, you cannot do that. But he said, we can do what we want. I was absolutely devastated. I didn't know how to get by. I had no money coming in. I couldn't keep up payments for my car, so that I got repossessed. My car really meant something to me. It was like my independence. I had all sorts of plans in my head. was going to visit family and I was going to go to Scotland and the lakes, but I can't do any of that now. I'm relying on other people now to drive me to hospital. I absolutely hate that. But it was my flat that was the real worry. It's just a small place. I live on my own. I just didn't have the money to pay the rent. I was hoping they'd give me more time. I was back and forth to the hospital, having scans and the like. They found the problem in the end, and it was a real shock. They told us I had cancer. Well, everything happened very quickly after that. I was straight into radiotherapy and told us they couldn't operate. All this was going on and I was getting letters from the landlord. I couldn't face them, so I didn't open them. I didn't know what to do. Every time I went out, I was worried that the locks would be changed and I wouldn't be able to get back in. I went to a friend's barbecue recently. I didn't want to eat because the food won't go down. I did manage to drink a bit though. I talked to my friends about the cancer and that they can't cure us. We talked about my funeral and what I want to happen. It's a bit morbid really, but my mates listened and I felt better for a while. Since my diagnosis, I've had help from Macmillan to sort my money. And that's really helped. Don't get me wrong, but there's just so much going on now. The radiotherapy makes me tired, but it's hard to sleep because my mind won't switch off. Things go round and round in my head. Like, what happens if I can't look after myself? I'll manage my own affairs. I can't get my head round it. I'm trying to keep positive, but I don't know. I just don't know what I'm being positive for.
So I think Dave's story shows really effectively this interrelationship between health and law. So in Dave's case, we start with a man with a serious health problem, which generates problems with work, leading to him being fired, loss of income, problems paying rent, risk of eviction, and risk of ultimately of homelessness. And you'll see from the slide that it's a vicious cycle. And actually, it doesn't really matter where you start. Serious health problems, chronic health problems can often cause social welfare problems. Social welfare problems can cause or exacerbate health problems. And the cycle can go round and round. So I mentioned this term social welfare legal problems. It's in the title of our ARC project. So what are these? These are matters of everyday life for which the law defines rights, entitlements, and protections. And therefore, the law is a route to resolution. And the law becomes a crucial part of delivery of holistic care. It's our friend in this situation. The social welfare law provides rights, entitlements, and protections across a range of areas of daily life. So some of them are here. That's not all of them, but these are the ones that typically interface with health issues. So there's income security, housing and property, employment and education, family, children, immigration status, protection from discrimination, abuse, or violence, and the right to community care. I think it's really helpful to think of this term social pathogens because this really emphasizes the point that social welfare legal needs can themselves be health harming. So just to give you another example, imagine a man who lives with chronic obstructive pulmonary disease and has repeated acute exacerbations. Now, the biomedical model will look to manage this with inhalers, steroids, and admitting him to hospital when he needs that. And that's fine. That's a really important part of his management, clearly. It goes without saying, really. But what if that man goes back to this accommodation shown on the picture, which is poor quality and damp? And actually that's fueling those exacerbations of COPD and exacerbating the problem that he's got with his chest. And what if there's a legal remedy? So for example, he's a tenant and there is a legal duty of the landlord to provide safe, healthy housing. there may also be income entitlement. So he may be able to financially rescue himself out of that situation. And the point that I'm trying to make essentially is that if we only focus on the biomedical model, we're missing a key part of this man's health and well-being. And this is what we're trying to achieve with a holistic approach. We need to have an integrated system. As part of our foundation work, we asked people living with an estimated prognosis of less than 12 months and their carers about their experience of social welfare legal needs. And this slide shows you what we found. I suspect there are no surprises here, but social welfare legal problems are prevalent. Everybody that we spoke to had experienced something, and the top three were finances, housing, and employment. Very importantly, these cause significant psychological and social burden, and for some people, these were incapacitating. Go away, cat. People really struggled to find help. They didn't know how to find help, where to even start. Those people who did get help, most of them had relied on engaged healthcare professionals to directly help or refer on, and more commonly that was about referring on to advice services. Because engaged health professionals are hit and miss, that led to significant delays. For some people, there were years and significant unmet needs. So there's a real problem here. And we're talking about delivering holistic care and palliative care, but we're not really doing that. And one of the things that we've really understood is that healthcare professionals are in a key role. And there's been research by Citizens Advice, which has shown that roughly 20% of GP consultations have a problem significantly related to social welfare problems or exclusively related to social welfare problems. It makes sense really that people who have social welfare legal needs impacting on health will use the NHS as an easily accessible, free source of support. So healthcare professionals can expect to meet people with significant social welfare problems. What we end up finding is that there are three key badges that healthcare professionals need to understand that they probably have, whether they like it or not. One is that they're critical noticers, and that means that they're critically placed to notice these problems because people are bringing them to them. They're also trusted intermediaries, so that means that they're trusted to find the right support, even if it's not them. And for social welfare legal problems, it probably won't be them. This is not our area of expertise, but there are services out there that can help. And thirdly, that they're compassionate communicators, and this particularly came to relevance around planning for the future and for people whose future looks like increasing incapacity and ultimately death, and what happens for people left behind. So those are the three key badges that we felt healthcare professionals need to be aware of in looking after social welfare legal problems as people get towards end of life. So the next question is, are healthcare professionals ready? The short answer is no, but they're keen. As part of our foundation work, we ran interprofessional workshops, and these were widely interprofessional. For example, we had groups with people from prisons, mental health professionals, carer representatives, domiciliary care providers, people from housing services, a whole range of different people, all in a room together. And we used stories like Dave's story to get people thinking about the issues that mattered to the people who were struggling, and that catalyzed discussion across the group, which was really rich. And a lot of that was about, who are you and what do you do? What's your role? I've never heard of that service. How do I access that? So it was really important cross-agency learning. And one of the things that we learned from that was that interprofessional education in itself may be a route to integrating services. But we recognise that if we were raising awareness of problems but not equipping professionals to know what to do if they identified them, we were essentially trading one problem for another. And that brings us on to the ARC project and our ambition for integration. And ultimately, what we're looking for is a system which allows accessible and equitable, regardless of diagnosis or place of care, and proactive access to social welfare legal support. We want to capitalise on the currently available services. That slide of the National Stakeholder Group will demonstrate, just even in a small part, that there are a lot of services out there who touch on this in some shape or form, and we need to be using those better. We want to learn from each other, capitalising on each other's experience and expertise. But we come into this knowing that there are some gaps, and the gaps that we know already are that accessible specialist legal advice is tricky because it's very difficult to get that free of charge, and that people struggle to help themselves. It's a combination of not being able to navigate the system. Who do I go to? How do I access them? What problem does this service deal with, or that service? But also the sheer volume of information on the internet is totally overwhelming, and people just find it disabling to start with. So that's where we're wanting to head, and those plug-in gaps are areas of interest for future research for us. Hannah, I'm going to hand on to you now. Would you be happy to take over and explain a little bit about human learning systems?
Yeah. Hi everybody. I think what Colette has described in terms of the system navigation and how complicated that can be, and how complicated and complex the needs of these people who have social welfare needs are, the ability to try to address that sounds like it could be a really, really large endeavour. And I think in appreciation of how big a bite we are taking off with this over the long term, we've adopted a complexity informed lens to this work. So that's basically just meaning that in order to accommodate the complexity of social welfare and legal services, especially in the context of health and social care, we need to adopt a complexity type of lens, which basically means that, as you'll see from this map, which is about obesity, that so many of these services are interconnected. The health and social welfare and legal problems are interconnected, and they're also dynamic, so they're moving all the time. So even this complicated map is a snapshot in time, and we blink and it will be different, and it would be different if there were other people in the room creating this map. And it's also emergent, so we don't know about it all yet, and we might never know about it all. And it's also really unpredictable. So although a still picture like this can't truly capture everything that we might want to, we're just trying to not ignore that reality. We cannot ignore the reality of how complicated and moving this subject area is. One of the people who we've been engaging with stakeholders over the last year or 18 months, locally and nationally, and one person said from HEE actually that complexity was jumping out at him even when he was listening to Dave's story, and that even if you had more time to navigate the services, it might not help. So the message that we want to build here is that even though we can build confidence in terms of thinking about what is solvable and how we can raise problems and how the law might help solve them, in complexity, maybe not everything even has a solution. And so the education, we want to build that narrative. There are many examples of patients and service users and professionals trying to find answers to problems at the end of life. And that might be the expectations around outcomes need to change potentially in some cases. So we just want to be open and appreciative of that as reality. Could you move on to the next slide, please? So the way that we're approaching this is using what we're calling human learning systems, which is a description of how people who are leading public services are trying to work with complexity. So over 400 organisations have been experimenting with the human learning systems approach, and we've been learning what that looks like. So this slide's just to give some of the key ideas that we're using to help frame this ARC project. Can you just click on Colette, please? So the first one is that the purpose of what professionals are trying to do is a nuance between services and service. So the service that we're trying to address here is meeting human needs and the variety of them. And variety baked into complexity informed services, and this matches our approach to the fact that we're trying to get many different professionals in the room from many different services, and that complex social needs also reflect that. We had a charity representative in our previous consultation with stakeholders who said that she was really surprised that she was able to contribute to the contribution as a non-health professional. And I think that mimics the multi-agency approach that we're trying to adopt, and how valuable people find actually just engaging in conversation with other people. And if we can do that in training, there's hope for the service. So a sort of bespoke by default approach to human public services is baked into what we're trying to do here. Click on.
Yep.
The role of management on using this sort of lens is less about meeting the services needs of sort of traditional targets and metrics and key performance indicators, and more about creating the conditions for learning. So when we adopt this learning focus as management, it allows us to do much better service development and service improvement. And one of the things that we've noticed with people when Colette has been doing the training is that empathy is invoked by Dave's story to the point where it triggers a motivation for people to want to do something different when they get back to practice. And that motivation is a really important element of putting learning into practice. So that's something that's really, really important for us. And this idea of learning becoming the focus for people who manage public services and being responsible for the conditions is why we're engaging service managers and service leaders in the ARC project that we're going on to do. So we're encapsulating that not just by delivering social welfare legal education to multi-agency frontline service providers, but also by inviting service managers and leaders, both locally and nationally, to work through their own systems map and to look at their sort of constellation of care as they see it at the moment, and to think, maybe this is not perfect, maybe there's something that we can do to improve it. But the notion that even managers can learn and sense make about their environment is absolutely critical to what we're trying to do here, as well as providing the social welfare legal training that includes Dave's story to the people who are delivering services. Click on Colette. And then leadership is actually about nurturing those systems. So when we can identify what we think that a current system or constellation of care looks like, which we'll do through effectively a workshopping type of setup, we can start to understand where some of those gaps are and what ones are addressable and what ones are pluggable. It's really interesting listening to some of the stakeholders we've engaged with so far. Some of them have described advice deserts, and other people think that the sector is absolutely chock-a-block full of advice, that we're overpopulated with advice services. And that's really interesting, I think, because it's highlighting that maybe there's an issue about the accessibility of these systems, and maybe that the structures aren't set up for the accessibility of them, but maybe they do exist. But it's really difficult for somebody who has a social welfare legal need to be able to navigate those, especially if the professionals who are trying to signpost them are appreciative of just how complicated it is. So I think that one person said that the multi-professional learning is largely in the too difficult box, and what we want to do is to try to address that, because it's not in the too difficult box because of a lack of need or a lack of desire or a lack of ability to deliver it. It's possibly to do with the fact that the educational systems are not set up for it. So the co-production workshops that we want to do is to help think through how that might be changed, and if we can get a little bit of the way there. So we're going to introduce participants to these ideas on this slide and encourage them to embrace the emergence of their integrated practice. And even if we're integrating practice and not systems, I think that that's going to be something that maybe patients can benefit from. Back over to you, Colette.
Thanks, Hannah. So just to finish off, a quick run through of the project elements for the ARC project that starts next month. So we're going to look at seeing what we can co-create with a local stakeholder group. We're not even quite sure what that's going to look like, as Hannah has shown with the obesity map, some sort of pathway, we think, with a geographical focus of Gateshead, because we understand that services are configured differently in any locality. So we've picked one, and that's where we're going to focus. We're pulling together a local stakeholder group at the moment, and Hannah, Mike and Rob will be running human learning system workshops, which will be informed by an initial PPI focus group. So we're going to be inviting members of the public with lived experience to help us understand what a responsive and accessible system needs to look like from their perspective. We'll be running IPE, interprofessional education, for frontline staff and service leaders if they want to be involved, which will be both raising awareness of the issues, getting people a bit more familiar, but also giving them learning from the human learning system workshop. So that may be a pathway, some sort of guidelines around how they can signpost, refer people on. The project will have a process evaluation culminating in a final event where we're going to bring everybody together, both involved in the local project, but also our national stakeholders, to have a look at what we've learned, what that means in terms of implications for scaling, and whether we can use this approach to co-creation more widely. So just to finish off, we're interested in other people who are interested in this area. As I say, I'm at the moment pulling together a local stakeholder group, so I'm very keen to know about any services which support health or social welfare legal needs for the Gateshead community, either local services or national services. So do let me know. I've got a few already, but I need that populated. We are talking about where the research goes. We've got lots of different strands we could focus on. So if this has synergy with work that you're involved with, please do let us know. And ultimately, we're aiming to influence national policy, and that's really ambitious, and we know it's ambitious. We reckon we've got a shot at it because our collaborators at UCL Centre for Access to Justice are working at national legal level to influence legal policy in line with integrated systems in Australia and the USA. So there are precedents for these integrated services, and they're trying to approach a national strategy. We also have an offer from Marie Curie to provide us with a voice around health issues at government level as well. So we've got offers and opportunities that we can capitalise on. So we're hoping that this will go somewhere, and we're really keen to have any thoughts, comments, or expressions of interest. So that's us done. Thank you very much for being part of the session, and be very interested to hear what you've got to say.
All right. Thank you very much. Thank you very much, Colette and Hannah. That was fascinating, absolutely fascinating. I've said that in the chat, if anybody has any questions, to pop them in. I've got one here. You can also stick your hand up and ask directly. And if I could see your hands, I would call you out, but I can't. So if you've got a question, unmute and shout, and I'll try and work around what we have. We've got one here from Victoria Arms.